idea of today, stock there. And Dr. Hosi Abraham does not need any introduction there. He's a professor and head of the Department of Infectious Diseases, CMC Vellore. But right now, he's a consultant Department of Medicine at CMC Vellore Chittoor complex there. And he got a lot of publications. And he's a clinician as well as researcher there. He got MD Medicine, Infectious Disease Training, and MPH. And he got a lot of publications. And he's a past president of SITS. Till 2020, 2021 is a past president of SITS. And everybody knows during COVID time, active in webinars and doing a lot of programs for the PGs and all the clinicians there. So, and his interest is also one of the good clinicians. He start dealing HIV. Very few clinicians who do HIV practices since almost 20, 25 years. Even before Clinical Infectious Disease Society started, I encountered Dr. Hosi with the HIV fellowship times during my Vellore stay in Government Medical College time, 2005, 2004, I remember that. So almost 20, 21 years I know him, sir. So, and he's a very good speaker. That's more important thing there. So without further wasting our time there, I'll just ask Dr. Osi to start his presentations, and sincerely thank Dr. Osi for giving this your valuable time and making this presentation. Thank you.
Okay. Good evening, friends. Am I audible?
You are audible, sir.
Okay. First of all, thank you very much, Suresh, for asking me to be here. Thanks also to Indian College of Physicians and APA. It's an honor and a privilege. Like Suresh said, I will be talking about approach to HIV in clinical practice. So I'll start with two patient stories. These are two real patients whom I had the privilege of being involved in their care in the last couple of years. Number one is a 32-year-old male. He's a carpenter by profession. He's absolutely asymptomatic, and he was planning to get married. Before that, he himself decided he wants to get an HIV test done. And he goes to a local laboratory, requests a test, and found to be seropositive. And then he comes to my clinic asking me, "Doctor, what should I do next?" Next patient is a more unfortunate story. We will call her RD. She's 53-year-old. She's a widow. She's brought to the hospital by her son. She's quite sick when she comes to us. She's come a long way from another state in our country. She has been having fever, has lost a lot of weight, and has developed multiple painful oral ulcers. All this has been going for about 6 months. During evaluation, she was tested HIV positive, and that's the reason why they have decided to come to CMC Vellore. On taking the history, she said that her husband passed away 15 years following a prolonged illness with fever and weight loss. She was not sure, neither was the son very sure whether he was HIV infected or not. So how do we proceed further? So we have two patients. And this is the outline of my presentation. During the evaluation, initial evaluation, first and foremost, we have to confirm the diagnosis of HIV infection. You have to be absolutely sure about the HIV infection. We also want to know whether it is HIV-1 or HIV-2. Second is detailed clinical evaluation to stage the infection, to diagnose the co-infections, other sexually transmitted infections, hepatitis B and hepatitis C, and comorbidities like diabetes, metabolic syndrome, coronary artery disease, chronic kidney disease, chronic liver disease, which have implications on choosing the most appropriate therapy also. And then the essential laboratory tests. Second thing is that preventive treatment. I will talk about cotrimoxazole preventive treatment or CPT, TB preventive treatment. There is one study, at least in African patients, where preventive treatment is more than cotrimoxazole and TB preventive treatment, what is called enhanced prophylaxis, and review that study briefly, and then talk about essential vaccines for PLHIV, and last but not least, about antiretroviral therapy. Confirming HIV infection. This is the algorithm from NACO, published in 2021. This is for clinically symptomatic individuals. NACO uses either enzyme immunoassay or the lateral flow assays, third generation tests which look for HIV antibodies in the patient's serum. So you have to do 3 tests, assay 1, assay 2, and assay 3. And all these 3 tests utilize either different three different methodology or three different kits, but on the same sample from the patient. So if the first test is negative, you can immediately tell the patient that this test report is negative, because these tests have a sensitivity of above 99.5% and specificity of more than 98%. That is mandated by NACO. So unless a patient has a recent high risk, risky sexual behavior, or like a needle stick injury or a contaminated blood transfusion, no risk factors are present, the test is negative, you can report that you are HIV negative because of the very high sensitivity of the test. But if the test is positive, you go ahead and do the second test, designated here as A2. And if both A1 and A2 are positive in a symptomatic individual, somebody who comes to you with a cryptococcal meningitis or pneumocystis pneumonia or cryptosporidium diarrhea, you can say that this patient has tested positive for HIV-1 or HIV-2 or a co-infection, HIV-1, 2, as the results may prove to be. So why do you want to do the second test? This is to improve the post-test probability. Actually, for all practical purpose, in a patient who has an AIDS-defining opportunistic infection, even one test positive, the post-test probability is extremely high. What if the second test is negative, discordant result? A1 is positive, A2 is negative. Then you have a tiebreaker, A3. And when all the three tests have concordantly positive, sorry, if the third test is positive, you declare this as an indeterminate test. And if the A2 and A3 are negative, you report it as negative. So if A1 is positive, A2 is negative, A3 is positive, this is an indeterminate result. A1 is positive, but A2 and A3 are negative, it is reported as negative. What do you do about indeterminate? There are two ways. Either call the patient back after a period of 4 to 6 weeks and do the test again, or send the patient for a nucleic acid amplification test. We'll talk about that in a minute. What about an asymptomatic individual? Remember, India is a low prevalence country. Our the HIV prevalence among adults above the age of 15 then it is less than 2%, extremely low. Because of the low probability, you have to do all the three tests, A1, A2, and A3. And then only if all the three tests are positive, you are reported as positive. This A1 is positive, you go ahead and do A2. A1 and A2 are positive, you go ahead and do the A3. And all the three are three different tests, rapid tests, third generation tests. So all the three tests are positive. This is declared as positive. Why do you want to do three tests serially? To improve the post-test probability or the positive predictive value of the test. So if the two tests are positive, it is declared as indeterminate. What do you do about indeterminate? You call them back after 4 to 6 weeks to look go over the problem of the window period, or do a PCR, nucleic acid amplification test. This is a recommendation from CDC. CDC recommends a 4th generation combined HIV 1 and 2 immunoassay. What's a 4th generation test? Third generation, first, second, and third generation tests only look for the presence of antibodies in the patient's serum or blood or plasma. 4th generation tests also look for the presence of P24 antigen. What's the advantage? You shorten the window period to about 14 days. Window period is from the time of infection till the test turned positive. So if you use the 4th generation test, you shorten the window period to about 2 weeks. So the HIV 1 and 2 immunoassay using a 4th generation test, rapid test. Subsequently, if it is positive, you do a differentiation immunoassay to determine whether it is HIV-1 infection, HIV-2 infection, or a co-infection with HIV-1 and 2. If it is negative or indeterminate, you go ahead and do an RNA. If RNA is positive, you go ahead and say that this is an acute HIV infection, and RNA is negative, you are declared HIV negative. This is the Western blot. Initially, you needed a Western blot to confirm the diagnosis of HIV infection. This is in the 1990s. We no longer use this test for several reasons. Number one, it is very expensive. The turnaround time is 2 to 3 weeks, maybe up to a month. It needs a expert technician or a virologist to do the test. And for the test to become positive, it can take anywhere up to 2 to 3 months. So the long turnaround time, the long window period, the need of sophisticated laboratory and trained personnel, costs, etc., Western blot is no longer recommended for diagnosis of HIV infection. This is the sequence of appearance of lab markers in HIV-1 infection. So this is the point where you get infected, percutaneous or sexual exposure. The HIV-1 RNA appears in the plasma by about day 10. So from day 0 to day 10 is called the eclipse period. So here, if you do an RNA test, nucleic acid amplification, you can diagnose HIV infection. The P24 antigen, which is present in the 4th generation assays, takes about 2 weeks to become positive. And the 3rd generation antibody test, which looks for the presence of IgG and IgM antibodies against HIV antigens in the serum, will take about 3 weeks or so. The Western blot classically took about 2 to 3 months to become positive. What are the situations where you will do a nucleic acid amplification test to look for the presence of HIV RNA or DNA in the peripheral blood mononuclear cells? There are 4 situations. Early infant diagnosis, I'll talk about a little bit in detail in the next slide. Acute HIV infection. So somebody has a risky sexual behavior or a needle stick injury or a blood transfusion, develops a compatible clinical syndrome, a mononucleosis-like illness, fever, rash, lymphadenopathy, splenomegaly, maybe an aseptic meningitis. The serological tests are negative, you go ahead and do an RNA test. If it's positive, you have to confirm it by a subsequent serological testing. This is essential. Indeterminate serology, we talked about this. And last and not least, blood donor screening. In CMC, the blood bank uses nucleic acid amplification test. NACO recommends only a 4th generation ELISA, but most blood banks nowadays do a RNA test because you want to absolutely make sure that the blood you use for transfusion is absolutely safe. This is a complicated diagram from NACO. National testing algorithm for HIV exposed children less than 18 months. Remember, maternal antibodies are transferred passively across the placental barrier and can remain detectable in the infant serum for up to 18 months. So, presence of an HIV antibodies in the infant serum does not necessarily confirm the diagnosis of HIV infection. All it means is that this baby is HIV exposed. So, what do? You do a nucleic acid amplification test. This is recommended at the age of 6 weeks, and the sample you use is a dried blood spot looking for the presence of HIV-1 RNA. So if the first PCR is positive, you collect a second sample also, and both tests are positive. So both PCRs are positive. Baby is declared as HIV-1 infected and referred for starting antiretroviral treatment. If the HIV-1 is not detected, and the first one is detected, that is a discordant result. First one is HIV positive, second sample does not detect the presence of nucleic acid for HIV-1, you refer it to send the patient to a referral laboratory. So if the patient is breastfed, you have to wait for about 4 to 6 weeks after cessation of breastfeeding, and then you do the test before you declare the infant to be negative. Even if the nucleic acid amplification test is positive, you do a serological test at 18 months of age to confirm the diagnosis of HIV-1 infection. So early infant diagnosis, acute seroconverting illness when the serological tests are negative, an indeterminate test when the serological tests are done, and finally for blood transfusion. These are the 4 indications for using the nucleic acid amplification test for diagnosis of HIV infection. Moving on to the clinical evaluation, most important is staging of HIV infection. Clinical staging, you know that WHO recommends clinical staging. There is no laboratory markers. stage 1 to stage 4, hierarchical staging, increasing degrees of immunodeficiency when you move from stage 1 to 2 to 3 to 4. Spontaneously, there is no regression of staging. Regression of staging happens only when you put the patient on antiretroviral therapy. So how do you stage HIV infection? If you go back to Dr. Chandrasekhar's lecture earlier, complete history and physical examination, extremely important. You have a full physical examination, which includes fundus examination, oral cavity, skin, genital examination, pelvic examination in women, complete physical examination. Why do you want to do this? To diagnose and treat opportunistic infections. Before you start antiretroviral therapy, appropriate treatment of opportunistic infections is extremely important for several reasons, including avoiding the phenomenon of immune reconstitution inflammatory syndrome. And this is done by a symptom-directed evaluation. Patient has headache and vomiting, you plan on imaging with lumbar puncture. Patient has cough and expectoration, you send a sputum for CBNAT, etc., etc. But there are two diseases which you screen for even in asymptomatic individuals, and those are tuberculosis and cryptococcosis. We'll talk about this in a little bit detail subsequently. STI screening is extremely important. You have to look for presence of other STI, syphilis, gonorrhea, etc., etc. How do you do that? History and physical. You ask for history of genital ulcers, urethral discharge, buboes, warts on the genitalia, lower abdominal pain in women. Do a physical examination, and in women, pelvic examination, pap smear with HPV DNA, and everybody should have a VDRL or a syphilis screen ELISA done. Minimum set of laboratory investigations, CBC, liver function test, creatinine, blood glucose, hepatitis B and hepatitis C virus, extremely important because they share the same route of transmission. CD4 T lymphocyte count to have a baseline. And if you're planning to start the patient on abacavir, you need HLA-B 5701 because the most serious adverse drug reaction to abacavir is a hypersensitivity reaction. The incidence which is 0 if the patient is HLA-B 5701 negative. I know that NACO does not recommend this as at the baseline. And finally, last but not least, counseling. Ideally, you should have trained counselors in your team, counsel the patient, everything. How is the disease transmitted? What's the natural history? How can you prevent? Healthy living tips. And last but not least, the benefits of antiretroviral therapy. How do you screen for tuberculosis? World Health Organization and National AIDS Organization, NACO, recommend that every PLHIV should be screened for tuberculosis at every visit to the clinic. So every PLHIV should be screened for tuberculosis at every visit to the clinic. How do you do that? A 4-symptom screening rule. And what are those 4 symptoms? Current cough, fever, weight loss, and night sweats, CFWS. So if the patient answers no to all these questions, no cough, no fever, no weight loss, no night sweats, it's highly sensitive to rule out active tuberculosis. The sensitivity, this is a meta-analysis, is 89%. Very high sensitivity. If the patient is not on ART. On ART, the sensitivity drops to about 50%. If you're adding a normal chest X-ray, that means no evidence of tuberculosis, no consolidation, no cavitation, no fibrosis, no lymphadenopathy, no pleural effusion, normal looking X-ray, and the patient is not on ART, the sensitivity improves from 89 to 94%. Patients on ART will have a lower sensitivity. So all these 4 symptoms, absence of all the 4 symptoms, current cough, fever, weight loss, and night sweats with a normal looking chest X-ray, very high degree of certainty of ruling out. Remember, a sensitive test is negative, you can rule out the disease. As you can see here, the negative predictive value is 99%. Okay, in India, the recently concluded National TB Prevalence Survey, our prevalence of microbiologically confirmed pulmonary tuberculosis about 320 per lakh of population. So it's less than 1%. So patient has answers no to all these 4 questions and has a normal looking chest X-ray, the very high degree of certainty you can rule out tuberculosis. That's how we screen for tuberculosis. When do you routinely screen for cryptococcal antigenemia? This is a recommendation primarily for African countries where the incidence of this condition, cryptococcal meningitis, is extremely high. So this is recommended for PLHIV with CD4 cell counts of less than 100. So they have very advanced disease and a setting with high prevalence, 5 to 100. In India, from Pune, from Delhi, reported prevalence from Varanasi, it's about 5% or so. NACO does not recommend in our setting at the moment. You use either a latex agglutination or a lateral flow assay in serum or plasma, point of care test with very high sensitivity and specificity. If the patient has headache, the test is positive and patient has symptoms of CNS involvement, severe headache, alteration in sensorium, papilledema, etc., you should do a lumbar puncture to rule out meningitis. If it's only antigenemia, no meningitis, you put them on preemptive treatment with fluconazole. That is 800 milligram once a day for 2 weeks and 400 OD for subsequent 8 weeks, and you delay antiretroviral therapy. I'll talk subsequently about TB preventive therapy in the next section. Now, moving on to HIV, staging of HIV infection. WHO staging moves from stage 1 to stage 4, hierarchical. Each stage represents increasing degrees of immunodeficiency. It's a clinical stage. Unlike the CDC staging has 2 axes, CD4 cell count and clinical information. WHO uses only clinical staging. Stage 1 is a patient who is absolutely asymptomatic. The CD4 cell count may be 50 or 500. Clinically, patient is asymptomatic. At the most, he or she may have persistent generalized lymphadenopathy, non-tender, firm, freely mobile lymph nodes in more than anatomically discontiguous areas. Histopathology, if done, will show only reactive hyperplasia. Stage 2 is minor mucocutaneous manifestations like seborrheic dermatitis, papular pruritic eruptions, itchy bumpy rash, fungal nail infections, onychomycosis, recurrent oral ulcerations, angular cheilitis, or herpes zoster within last 5 years. All these conditions, seborrheic dermatitis, fungal nail infections, herpes zoster, none of them are specific for HIV infection, but severe manifestations, recurrent manifestations, and herpes zoster usually in a young individual is unusual. So a 20-year-old comes with herpes zoster, you should think of HIV infection. So minor mucocutaneous infection and herpes zoster is WHO clinical stage. WHO clinical stage 3 is minor opportunistic infections or persistent chronic diarrhea or weight loss more than 10% or persistent fever. So you don't have lab facilities. You can only do so much by way of investigations. So there is weight loss unexplained, diarrhea unexplained, persistent fever unexplained, or persisting for more than a month. Minor OIs are oral candidiasis, but if there is esophageal candidiasis, it becomes stage 4. Oral hairy leukoplakia, pulmonary tuberculosis, not extrapulmonary, severe bacterial infections like pneumonia or pyomyositis, and non-infectious conditions like anemia, neutropenia, and thrombocytopenia. Remember, unexplained thrombocytopenia, you should think of SLE and HIV infection. WHO clinical stage 4 is advanced immunodeficiency, AIDS defining opportunistic infections. So this is in CDC, this will be CDC 3. So it can be bacterial infections or mycobacterial infections, extrapulmonary tuberculosis, or disseminated atypical mycobacterial infection. Most common being mycobacterial.
Please, everyone, mute yourself. Please, all mute yourself. Dr. Abhilash Jain, please mute yourself.
Recurrent severe bacterial pneumonia. Thanks, Suresh. Non-typhoidal Salmonella typhimurium, not Salmonella typhi. It can cause, usually in an immunocompetent individual, it will only cause a self-limiting diarrhea, but here you can have bacteremias. Then fungal infections like pneumocystis pneumonia, esophageal candidiasis, cryptococcosis, most common being cryptococcal meningitis, disseminated mycosis like histoplasmosis and tularomycosis, viral infections like chronic herpes simplex infection, present for more than 1 month, severe, extremely severe painful ulcers going on for more than a month, disseminated CME disease, CME of the eye retina, CME of the central nervous system, protozoal infections like cerebral toxoplasmosis, cryptosporidiosis, and isospora causing diarrhea. 3 cancers, age-defining cancers are lymphoma, especially cerebral, primary cerebral lymphoma and diffuse large B-cell lymphoma caused by EB virus, invasive carcinoma cervix caused by HPV, and Kaposi sarcoma, extremely rare in our country, caused by HHV-8. These are all viral viruses causing cancer. And non-infectious conditions like HIV encephalopathy, primarily cognitive decline, HIV-associated nephropathy, rapidly progressive renal failure with proteinuria, HIV-associated cardiomyopathy, a dilated cardiomyopathy, and HIV wasting syndrome. So bacterial infections, fungal infections, viral infections, protozoal infections, HIV-associated cancers, and a variety of non-infectious conditions. So all these are AIDS-defining opportunistic infections. Now we'll go through some clinical exercises. So this is a patient with PLHIV with fever, cough, and weight loss, cough with expectoration. CBNAT showed MTB high and resistance not detected. You can see lower zone infiltrates. What will be the clinical stage here? This will be clinical stage 3, pulmonary tuberculosis. This young lady has fever and weight loss, multiple enlarged lymph nodes, lymph node aspirate MTB detected, RIF resistance not detected, also has herpes simplex. So this is extrapulmonary tuberculosis. Extrapulmonary and disseminated TB mycobacteremia becomes stage 4. This is dewdrops on rose petals, grouped vesicular rash in a dermatomal distribution, antecedent severe pain. This is herpes zoster, WHO clinical stage 2. These are flesh-colored papules and nodules. Some of them are really big. Some of them are umbilicated, if you can see closely. This is molluscum contagiosum, but it can also be a manifestation of mycosis like cryptococcosis, tularomycosis, and histoplasmosis. So skin and mucosal lesions in advanced HIV infection, think of disseminated mycosis, cryptococcosis, histoplasmosis, and tularomycosis. Tularomycosis is for patients from northeastern part of India. This is oral thrush, WHO clinical stage 3. This patient also has odynophagia, pain and discomfort, retrosternal pain and discomfort while swallowing, a symptom with very high positive predictive value for esophagitis. You can assume that this patient has esophageal candidiasis also and becomes clinical stage 4. So coming back to our patients, patient has hepatitis B was negative. He had a completely normal physical examination. He was asymptomatic. Hepatitis B and C were negative. VDRL was negative. His chest X-ray was normal. His CD4 was around 600. He was referred to the ART center for antiretroviral therapy. And then he started ART, the TLD regimen, and he's doing very well on follow-up. He got married subsequently. Patient RD, the story was sadder. This patient had oral, vulvovaginal, and esophageal candidiasis. Cryptococcal antigen was, CD4 cell count was something like 30. Cryptococcal antigen was positive. She also had an E. coli bloodstream infection, primary bacteremia, which can occur in advanced HIV due to hyperinfection due to strongyloidiasis. Bone marrow also showed a diffuse large B-cell lymphoma. So she had advanced disease. The son wanted to take her back because given her very advanced disease, we gave them the address of the local ART center. When we tried to contact them later, we were unable to contact. So unfortunately, this patient was lost to follow-up. Most likely, she would have succumbed to her disease. So this was a sad story. So now talking about preventive treatment, I will talk about cotrimoxazole preventive therapy or CPT, TB preventive therapy, which was initially called isoniazid preventive therapy. Now it is called TB preventive therapy or TPT, and enhanced prophylaxis. So Bactrim keeps the doctor away is something you can remember. Cotrimoxazole prophylaxis reduces mortality, morbid events, and hospitalization, and the relative risks are all given there. So 960 milligrams or one double strength tablet once a day is recommended for every patient who is in WHO clinical stage 3 or 4, or when the CD4 cell count is less than 350. You stop cotrimoxazole prophylaxis once the patient is on ART and you have 2 CD4 cell counts above 356 months apart. Tuberculosis preventive therapy. This is the original meta-analysis, Cochrane review published in 2010. 8,500 patients in the meta-analysis, reduces the risk of tuberculosis, active tuberculosis, by about 32%. Number needed to treat is about 50, and significant benefit. This included everybody with positive tuberculin skin test and without a skin test. There was an interaction between positive skin tests. The benefit was better. Look at the relatives, 0.68 here, 0.38 here. This was only isoniazid preventive therapy. There was no effect on mortality. Although it reduced incidence of tuberculosis, there was no effect on mortality. So what about IPT in the ART era? Yes, it works even in patients on antiretroviral therapy. So addition of isoniazid to antiretroviral therapy reduces the incidence of tuberculosis. The relative risk is about 0.68, very similar to the previous one. Here also there is no effect on mortality. So our national program recommends either isoniazid monotherapy for 6 months or combination of rifampicin with isoniazid once a week, 900 milligrams of isoniazid plus 900 milligrams of rifampicin, either individual pills or a combo pill, one pill once a week for 3 months. That is 12 doses. So this is the algorithm recommended by NACO. The 4 symptoms. I'll talk only about adults. I'm an adult physician. Current cough, fever, weight loss, night sweats. If all are no, see whether there are any contraindications for TB preventive therapy. They are once active tuberculosis is ruled out, patients who are heavy consumers of alcohol, patients who have acute or chronic liver disease, patients who are on other hepatotoxic medications, or patients that have significant peripheral neuropathy. If no contraindications are there, you give preventive therapy. If this answers yes to these questions, go ahead and investigate for tuberculosis, TB or not TB or other diagnosis, and then TB is ruled out, you can go ahead and plan on preventive therapy if there are no contraindications. Enhanced prophylaxis. In Africa, a substantial number of patients, 25 to 30%, present with very advanced disease. CD4 cell count like 50, bedridden, advanced opportunistic infection, disseminated tuberculosis, cryptococcosis. So this randomized control trial gave isoniazid and trimethoprim sulfamethoxazole plus single dose albendazole plus azithromycin for 5 days plus 12 weeks of fluconazole. This was for PLHIV with CD4 less than 100. As you can see here, mortality was lower with enhanced prophylaxis, 14.4 versus 11%. So number needed to treat will be something like 33. So this is something you can consider for patients with advanced disease, especially in settings with very high incidence of cryptococcal meningitis, and but not recommended by NACO in our country. What are the vaccines recommended for PLHIV? Hepatitis B if they are not immune. So hepatitis B surface antigen is negative. Go ahead and immunize them with the standard 3-dose regimen. Tetanus or TD booster once every 10 years. Pneumococcal vaccine, PCV13. This is the conjugate vaccine initially, followed at least 8 weeks later by the PPSV23. Not part of the national program, little expensive, but if the patient can afford, go ahead and give it. Annual influenza vaccine. And if the patient is not immune and has CD4 cell count above 200, remember this is a live vaccine, so don't give for patients with advanced immunodeficiency. Again, an expensive vaccine, not part of the national program. So if the patient can afford, go ahead and give it. Last but not least, antiretroviral treatment. Currently, antiretroviral therapy is recommended for everybody with a diagnosed confirmed HIV infection, irrespective of the clinical stage, irrespective of the CD4 cell count. Strong recommendation based on moderate quality of evidence. Priorities for those with advanced HIV clinical disease, WHO clinical stage 3 or 4, or CD4 cell count less than 350. All guidelines, World Health Organization, National AIDS Control Organization, International AIDS Society, European guidelines, British guidelines, US guidelines. So everybody says, so once you're diagnosed to be confirmed with HIV positive, make sure they are on antiretroviral therapy. The evidence of this is from these two randomized controlled trials published in NEJM in 2015, the Insight START study and Temprano ANR study. This is an international study, included patients from India, 2 centers in India. This is an African study. This showed that it reduces disease progression and death due to HIV. It reduces it by about 60%. Hazard ratio is 0.43 and the number needed to treat is 43. So antiretroviral therapy, irrespective of the stage, irrespective of CD4 cell count, reduces death from AIDS, reduces progression to more advanced forms of the disease. Not only that, it prevents the progression of disease and mortality, it also prevents transmission. This is the HPTN 052, which looked at antiretroviral therapy in serodiscordant couples. One partner was HIV infected, other partner was HIV uninfected. The infected partner did not have indications for antiretroviral therapy. This is when the study was done. CD4 cell count above 350 was asymptomatic. They were given antiretroviral therapy, randomized to receive either ART or delay ART, and it reduced new infections. No linked infection. That means genetically identical virus infecting both partners. No linked infections were observed when HIV infection was stably suppressed by ART in the index participant. That means the infected partner was on ART, fully suppressed viral replication. He or she did not pass on the infection to the uninfected partner despite condomless sex. This was subsequently confirmed in large study called partner studies, partner 1 and 2, looked at gay couples, looked at heterosexual couples, zero HIV transmission through condomless penetrative sex, zero HIV transmission. So now we know that undetectable is untransmittable. So if the HIV infected patient is on antiretroviral therapy, stable antiretroviral therapy has undetectable plasma viral load, fully suppressed viral replication, he or she will not transfer to the uninfected partners. So HIV antiretroviral therapy is good for the patient, good for the community. So once HIV is diagnosed, current recommendations is start HIV antiretroviral therapy within 7 days of diagnosis, following confirmed diagnosis. So all the things I told about diagnosis and clinical evaluation, which I said, clinical evaluation, appropriate laboratory tests. And if the patient is ready, start on the same day. Why do you do that? Reduces loss to follow-up, reduces transmission to the partners, and improves outcomes like mortality and viral load suppression. What about a patient who has an active opportunistic infection? Of course, treatment of opportunistic infections take precedence, but you treat the PCP, treat the cryptosporidiosis, but within less than 2 weeks of initiation of OI treatment, you start antiretroviral therapy. The two exceptions to this rule are tuberculous meningitis and cryptococcal meningitis. As you can see here, both are CNS infections. So, if you start ART early, in cryptococcal meningitis, you have RCT showing that mortality is higher with early initiation of ART. The Vietnamese RCT in TB meningitis showed that there was no difference in outcome, but adverse events were much higher with the early ART. Remember, this is an OI occurring in a closed compartment. Iris is very bad in the nervous system. So TB meningitis and cryptococcal meningitis, you defer therapy, antiretroviral therapy. And the initial ART regimen for most patients is today a combination of tenofovir, lamivudine, and dolutegravir. Why is that? Randomized controlled trials, head-to-head comparison. This is superior to efavirenz and boosted protease inhibitors. It is dolutegravir is effective against both HIV-1 and HIV-2, well tolerated, hardly any side effects, single tablet regimen, hardly any drug interactions unless the patient is on rifampin-containing regimens for tuberculosis. You need an extra dose of dolutegravir and high genetic barrier to resistance. So, number of reasons why this is almost a universal ART regimen. So, to conclude, the evaluation of a newly diagnosed HIV-infected patient after confirming the infection is symptom-directed evaluation. You screen for tuberculosis, screen for TB using the 4-symptom questionnaire plus minus a chest X-ray at every visit to the clinic, and cryptococcosis if the CD4 cell count is less than 100. Prophylaxis is TPT and CPT, not prophylaxis, preventive treatment, and ART, treat all and treat rapidly. So I'll conclude my presentation here. Before I conclude, I would also like to invite all of you for the annual conference of our society, SIDS. Suresh is also here. He is also a governing council member. So SIDSCon happens in Mumbai this year. So please do register. Early bird registrations are still open. Thank you very much. Over to you, Suresh.
Thank you for the wonderful presentations. You touched upon all the aspects of the HIV, what clinicians supposed to know. Thank you for your presentations. The usual routine is after the presentations, we check what is, because you conducted a lot of clinical case scenarios and you tested the knowledge of the PGs also. We just run the posters to see whether people are picking up or not. Meantime, a lot of interesting questions are posted in the chat box. You can review so that I can ask you at the end of the poster session, sir. So I just check. I'm not able to share. Just check. 1 second.
I can see the chat box.
Yeah.
Shall I read? Okay.
Once posters is over, then we can start. So 1 second, I just check.
Okay. Shall I go through the questions in the chat box?
No, 1 second, sir. Posters will finish. Shall we just go through in meantime?
Okay,
So we
okay,
can answer
sure,
a couple of things, sir.
sure.
1 second. It's not sharing. தெரியுமா? Yeah. Okay, so I think some issues there. So meantime, we can finish it off there.
Okay.
Can you elaborate A1, A2, A3? What are all the test methods? So can you elaborate some light on A1, A2, A3?
Okay. NACO recommends rapid tests only. Either the EIA, enzyme immunoassay, or a lateral flow dot blot assays. A1, A2, A3 are 3 different tests. So you don't do the same EIA as A1, A2, and A3. It will be 3 different tests. So 3 different commercial tests or 3 different techniques. One is an EIA, one is a dot blot test. All are rapid tests, all are third generation tests. third generation test meaning it is a test contains antigens, recombinant antigens, which look for the presence of IgM and IgG antibodies in the patient's serum. So if the A1 is positive, so the same sample, you don't draw a separate sample. So A1 is negative, you tell the patient you are HIV negative unless there is a recent risky sexual behavior or patient has got a blood transfusion or had an ill sick injury. If A1 is positive, you go ahead and do the second test, A2. If both are positive and the pretest probability is high, that means the patient has come to the STI clinic or has a opportunistic infection, you declare the patient as positive. If the patient is asymptomatic, because of the low pretest probability, A1 is positive, A2 is positive, you go ahead and do the third test. If all the three tests are positive, then only you declare the patient positive, and it's also the results are declared in the context of post-test counseling. If only two tests are positive, it is an indeterminate test. So either you can wait and repeat the test after 4 to 6 weeks or go ahead and do a RNA test. Over to you, Suresh.
Second question is, one of the patient has got systemic hypertension and admitted for intracranial bleed. Subsequently diagnosed HIV positive with high viral load, but CD4 count was 730. Started on TLD regimen, but he came back with blurring of visions and papilledema within 3 to 4 days. What should be the cause? Whether opportunistic infections can happen at the high CD4 count, or this is primarily basically because of the disease related, or any other things we can suspect? That's a clinical question he's asking.
At 730, an opportunistic infection will be extremely unusual. The CNS-OIs are most frequent is cryptococcal meningitis, followed by tuberculous meningitis, followed by cerebral toxoplasmosis, followed by cytomegalovirus encephalitis, CME encephalitis. At 730, none of these are likely to happen. And only thing I can think of is that was it hypertensive? Okay, it was hypertensive intracerebral hemorrhage. So it is not a large toxoplasma encephalitis being mistaken for bleed. So it's unlikely to be used due to HIV or the treatment. You should look for some other cause for the papilledema. Would you add anything, Suresh? Would you add anything?
What we can do. One interesting question is I am coming out before I start the posters questions. Before this is an interesting stuff. TB is common in India, but still, why you call TB as an opportunistic infections in HIV?
Okay, very good question. Okay, tuberculosis is not an opportunistic pathogen. Anyone can get TB. M tuberculosis is a professional pathogen. It's not an opportunist. But the way tuberculosis presents is what makes it an opportunistic infection. Most of the TB you see in your clinical practice in immune competent individuals is a fibrocavitary disease. Patient has cough, fever, weight loss, fibrosis, cavity on chest X-ray, sputum smear is positive. When with increasing degrees of immunodeficiency, TB goes outside the lungs. You get extrapulmonary and disseminated forms of tuberculosis. Even in the lung, it is lower zone. Remember the patient I showed you? The lower zone infiltrates. There is no fibrosis, no cavitation. And sputum smears may be negative, but expert will, CBNAT will remain positive. In our series, most common was extrapulmonary and disseminated tuberculosis. And we have quite a few patients with mycobacteremia, a bone marrow culture or a blood culture growing M tuberculosis. And then if you have TB lymphadenitis, in an immune competent individual, you biopsy, you will find well-formed KC, necrotizing granulomatous inflammation. But if you, in a PLHIV with advanced disease, there will only be necrosis, no granuloma formation, and it will be teeming with acid-fast bacilli. So the way TB presents and the host response, that is what makes it an OI.
Okay. So meantime, I'll post a couple of posters questions. Right now, my slides are visible, I hope. So this is my disclosure. This is a place where I learned HIV medicine, Government Hospital of Thoracic Medicines. where we do a lot of HIV cases there in 2002, 2003. A lot of cases we see. This is a famous Ward 28, where each bed is occupied by 3 patients in 2004, and almost all the opportunistic infections we learned it in 2003, 2004. That this is my disclosures. So, which one is easy to manage? How many people say COVID is easy to manage or HIV is easy to manage? Right now, HIV is facing a lot of fund cut from the government of US there. So, what do you think? Which is easy to manage in the presence of fund cuts and the disease and disease? So, just for fun only there. Dr. Osi, what do you think? Which one is easy to manage?
um, I think HIV today is easy to manage.
COVID, the long COVID has been difficult to tackle it, and we do not know exact diagnostic method and exact proving method there. HIV, at least we know, is easy to control it there. So I've shown a couple of cases already. Dr. Hosi also alluded these cases there. So what do you think? 26-year-old female, 4 years of married, planning pregnancy, pap smears showing abnormality. Whether this person is possible HIV, or 65-year-old female, non-Hodgkin's lymphoma, no response to 6 cycles of chemotherapy, hysterectomy 20 years back. Can you think HIV in this lady? 28-year-old male from Salem, working in Chennai, sales executive, fever, sore throat, cervical node of 1 week durations.
Mhm.
30-year-old male, no comorbids, herpes zoster. I think a couple of cases Dr. Hosi already discussed. So what do you think? All of the above, I want to see the responses from the participants. If you really want the utterance of the certificate course, please go ahead and chat bot what is your thinking about it so that we can discuss. I can't able to see today there. So what is the responses in the chat box? Which one is the preferred drug? People say five, all of the above, or four. People say herpes zoster. The point is well taken right now. Okay. So nowadays, the clinical suspicion has changed. Previously, we considered high risk activity, sexually transmitted diseases, tuberculosis, fever of unknown origin. Right now, the spectrum is changing. Even couple of diseases like non-Hodgkin's lymphoma, CA cervix, lung cancer, these are all considered HIV-associated malignancy or age-defining malignancies there. So we need to think about it there. So, okay, how will you test a person when you suspect HIV? Or you want to send the person to ICTC, Integrated Counseling and Testing Center, or just take the consent and take samples. Or take sample if it is positive, counsel it, or take sample if positive, you can abscond the patients to refer to the other patients, other hospitals, or do rapid test before doing some proper test. What are you going to do? What is your practices? This is one of the famous campaign they promoted for testings and promoted the ICTC counseling in way back in 2000s. There, everybody in the 2000, those who practice HIV, this campaign is a very famous campaign. People say they refer to ICTC. They say take consent and take samples there, whether informed consent or whether it's a written consent. A lot of issues as per the NACO. We need to take a still. Dr. Osi, can you throw light on the consent part of it?
Yeah. uh, NACO is very clear in its guidelines. HIV testing is voluntary and it occurs with informed consent and pre and post test counseling. It's very clear. The mandatory HIV testing occurs in blood and organ donation prior to, that is to protect the recipient. STI clinic, antenatal clinic, patients with suspected OI, chronic hepatitis, HIV associated cancers, everywhere it is voluntary and informed. So ICTCs are even in CMC there is ICTC. So it's very easy. You walk in, it's free. You get the reports back in about an hour or two. Now, having said that, I think today our threshold for doing an HIV test should be very low, like Suresh said in his previous slide. Why is that? Number one, availability of potent, effective, safe antiretroviral therapy, and that too free of cost. ART centers are all over the thing. And it protects the patient, quality and quantity of life is maintained, and it prevents onward transmission. So we should keep we have now a generation of doctors, MBBS and MD and MS, who don't see PLHIV as we used to see. So people are not, the clinical manifestation may not be that overt as we used to. So we should have a low threshold for testing is what I personally feel.
Correct. That's what we do. But rightly pointed out by you, The opt out and opt in testing. We can, when a person comes to your hospitals, don't judge the patients on risk factors and anything there. You can provide an opportunity. If you're able to test the persons, it can link to the services, particularly treatment services and prevention services. People are putting questions on you for you. Once the person put on the treatment, if the viral load is not detected, we can prevent the transmissions. It helps ending the strategy. That's called opt-out strategy. Is possible, but we need to do the proper counseling and we need to offer the testing. After the test is positive, some other people say you don't provide the services, go to the other hospital. That's not there. This is giving an option to the patients for a routine care. When a patient comes for some other reasons, whatever test I'm going to do, in addition to the test, I'll do HIV. If HIV is positive, we can provide a good care to you there. We can provide the counseling. This strategy worked well in 2009, and we put the paper in IDSA and got the best paper award also. So this is an interesting case here. 41-year-old male, infertility workup. Because infertility, we told one of the reasons we need to suspect HIV also. The person being tested for infertility, you decided to do a HIV test. What test you want to do there? So what is the method you prefer? We already discussed the thing. So what do you think? The person's results I just given here now. HBsAg is non-reactive, HIV is non-reactive, HCV is non-reactive. What will you do now? The person came for infertility with the bring HIV report as per your suggestions done in one of the small hospitals, nursing homes, and came with this report. HBsAg non-reactive, HCV non-reactive, HIV non-reactive. How many says clear for infertility workup? No, HIV is negative. As per the policy, so people say clear. A couple of us say has to resist high risk behavior. People want to know. They well versed in history taking. Okay. So a person within a month's time presents with oral ulcers. So the repeat HIV test was done within a month's time. What do you call this person suffering from? Whether the previous report was a false report or this one is a false one, or the person has got in between on window period getting converted. What do you think? Say symptomatic treatment and wait. People are offering there. So July test is negative. August test, all three methods is positive. Can we call acute retroviral? He already allotted, but acute retroviral, the antibody testing will be negative. Usually we go with the viral load testings or PCR testing is the way forward to find that point of time. So the antibody negative, whether it's converting from incubation window period to conversion is one possibility we can think of, but we can't say acute retroviral syndrome once the antibody test is came positive. It's very difficult at that point of time. Only the oral ulcers is the presentations. So already these things are eluded. So this is a quality of testing we need to remember. What method? No mention about it. So if we send a sample, do proper lab. What method? At least they mentioned rapid CAR test or they mention about fourth generation ELISA. What is the test? That is more important. Just putting negative, non-reactive, always take pinch of salt. But this is fine. But what do you think about it, Western blot? Whether can anyone read this Western blot? HIV, the same person underwent a HIV Western blot test. GP 160 is positive, P24 is positive. Whether it's getting acute HIV infection now, you need to type your answers now. Whether it's acute HIV, so the interpretations of the Western blot is challenging. So a lot of confusions. It creates more confusions rather than solving the problem. So we are not relying it. For example, the final report is HIV indeterminate because two glycoprotein envelope proteins should be positive along with P24. But here only one glycoprotein antigen is positive. So we can't interpret the test. So this is why the CDC algorithm and NACO algorithm, Dr. OC has already alluded what we need to do. That's the best thing. So Western blot has got no role in 2025. I can put it right now. And unfortunately, this person's HIV determined indeterminate. So some lab it is positive. So always take pinch of salt whenever you're interpreting with the serology report. Always go with the clinical picture. This person vouchers I don't have any extrametal contact, no transfusion, nothing. So when we did the ID net, this type of confusions, we need to go with an ID net and proved ID net is negative, so we cleared it. And this OA already Dr. OC has touched upon it. What will you do? The person has got recently diagnosed HIV positive, 2 weeks of fever and shortness of breath, 10 days durations. What will you do now? Given the choices now.
Hmm.
This is the last case I keep because I want a lot of questions to be answered with Dr. Uzi there. People say start cotrimoxazole, ask viral load and CD4 count, but the person is sick, so start treating. So people are thinking this is a PCP pneumonia. Yes, fine, but no hurry to start ART. The dictum or the principle in HIV medicines, Always treat opportunistic infection first, whatever be the CD4 count, whatever be the viral load. Treat the OA. HIV is not a urgency emergency. We can treat HIV bit later. Otherwise, OA will kill the person. That's the moral of the story. A lot of OA is already told. This cases is alluded by Dr. OC already. This is again genital wart. So, and again, this is papillopleuritic eruptions, one of the common manifestations. Oral candidiasis. Wasting this disease we are not seeing nowadays. With the advent of good ART, we are seeing other end of the spectrum, more of obesities, and we are seeing it right now. So this is needle stick injury. We alluded already previously. So I just stopped sharing here. I asked Dr. Osi, you can touch about brief 1 month INH plus rifampicin in HIV. What is the role?
Okay, so the TPT regimens which you can use are 6 months of isoniazid monotherapy, 4 months of rifampicin monotherapy, 3 months of daily rifampicin plus isoniazid, 3 months, but given once a week, combination of rifampicin and isoniazid. So that will be 12 doses, 900 milligrams each, or 1 month of daily rifampicin with isoniazid. The TPT regimens recommended by our national program is either 6 months of isoniazid monotherapy or 3 monthly combination of rifampicin and isoniazid given as weekly doses. That will be 12 doses. So that will be there is a combo pill available. There are individual pill available. I don't think it's rolled out all across the country. Is it available in Chennai, Suresh?
No, sir. No, right now it's not available. In government programs, it's available. The public health sector is available,
Public
but not
sector.
in private care.
Okay.
And I
So
agree with that thing there. Correct.
yeah, so the randomized control trials have shown that the rifampicin isoniazid is equivalent, non-inferior to isoniazid monotherapy. Better completion because of less side effects. But the contraindications are the same. Pre-existing liver disease, acute or chronic, history of heavy ethanol use, peripheral neuropathy, concomitant use of hepatotoxic medications. Some concern about flu-like syndrome caused by rifampicin. So that's one concern. Peripheral neuropathy is another concern. So it's being ruled out, promoted aggressively by the government for PLHIV and household contacts of pulmonary tuberculosis in our country.
Yes. Only thing like people say interactions with the ART, but rifampicin has got least interactions compared to the rifampicin. So
Sure.
that we need to closely monitor. And pregnancy, the data is not that strong there. So
Thank you,
always keep
Suresh.
complaints.
Thanks.
So regarding breastfeeding, whether it's contraindicated in HIV positive mother?
No, absolutely not. In fact, WHO and NACO recommends exclusive breastfeeding for 6 months. So you need to do the test after cessation of breastfeeding. It's not a contraindication.
So don't combine both. Like a mixed feeding is problem there. Either you want to go
Absolutely.
with the formula or you can go with the breastfeeding, but breastfeeding is not contraindicated.
Absolutely.
Advice on getting married for a HIV positive person, whether he can get married.
Yeah. So, yeah. So U is equal to U. So PLHIV who is on stable antiretroviral therapy should have completed at least 6 months stably, good adherence, and 2 viral loads 6 months apart are undetectable below the lower limit of quantification, target not detected, and no other sexually transmitted infections. The risk of this person transmitting to his or her partner is 0. HPT and 052 and partner 1 and partner 2 studies. But then this should be done with an open, meaning both partners should be aware of this thing. I have had my patients getting married, having children, and the partner has not been infected. The child has not been infected. So HIV infection is not a contraindication to getting married.
Yes. Regarding the durations of TPT and IPT to all, I combine both the questions together.
Yeah. So like I said, every PLHIV at every clinic visit should be screened for tuberculosis, and screen is negative, and there are no contraindications for IPT/TPT. Should be on therapy. In CMC, we have a NACO funded ART center. About 2,500 patients are being followed up. Only IPT is being given. TPT, the rifampicin regimen has not come to Vellore as yet. So,
Then another interesting question is when to start ART in a person with TB meningitis?
okay. Okay. Generally, 2 weeks is the time from OI treatment to antiretroviral therapy. Exemptions are TB meningitis and cryptococcal meningitis. So you wait about 4 to 6 weeks. You make sure that patient is fully adherent to the anti-tuberculous therapy. You make sure the symptoms have improved dramatically, no drug toxicity, no features of iris or paradoxical worsening. So 4 to 6 weeks, and then you start the antiretroviral therapy.
Can we start ART along with the syphilis treatment?
Absolutely, yes, you can.
Okay. Post-exposure prophylaxis if HIV infected blood spilled over nail blood which are recently cut. Is there a risk of transmissions and which post-exposure prophylaxis tests are best if needed in the scenario? Post-exposure prophylaxis in HIV infected blood exposure where the nail blood was recently cut.
Okay. So, uh, the highest uh, probability of transmission is a needle stick injury. Visibly contaminated hollow bore needle pokes the health professional and draws blood. So that is also 3 per 1,000. So this is there is an open wound on the skin and there
Blood
is no
exposure.
glove and there is blood over it. Yeah, I will prophylax TLD regimen for 28 days started ASAP.
One patient come to my OPD with a high-risk sexual contact 1 week back. He doesn't know the serology of the partner, commercial sex worker. Want to test HIV now. How to manage?
Okay, 1 week. Yeah,
Yes.
you can offer the fourth generation test if it's negative, uh, or the NACO, the third generation test. If it's negative, uh, counsel him or her and call back after 4 to 6 weeks, or refer the patient for uh, RNA test if there is a syndrome compatible with the mononuclear acute seroconverting illness.
Yes. Usually the baseline testing we can do. This is when they do at the seventh day, it's called baseline, previous status.
Yeah,
So don't tell the thing that 4 weeks later, what
yeah,
Dr. OC has said we need to do.
yeah.
As TPT, he said TPT is not available freely to us. As TPT reduce the incidence of TB in Indian setting is asking there. No data there right now.
Well, we have meta-analysis showing that isoniazid preventive therapy reduces the incidence of active tuberculosis even in patients already on antiretroviral therapy by about 30-32%. The relative risk is 0.68. Has it translated to reduce incidence and prevalence of TB in the community? Answer is unfortunately no. So this is an intervention which has very high efficacy in randomized controlled trials. Unfortunately, it has not been translated to effectiveness in the community. Why is that? One is poor uptake, uh, uh, meaning even as health professionals, whether it works, whether there will be toxicity, whether it will lead to emergence of resistance, a lot of concerns. So,
I sincerely thank Dr. Hosi for spending valuable time. Questions keep on coming there, but we have overshot already 10 minutes of our time. I thank the AP and ICP for giving this wonderful opportunity. I thank the Dr. Hosi for giving this wonderful lecture. You keep the people till the end, and people keep on bombarding with questions till the end there. And very interesting questions are to answer also. That's more important. Thank you for your participations. Usually, it's very difficult to learn one session there. You need to read about it. So next 1 week, read about HIV. A lot of questions will be asked in your certificate examination. It's going to happen in July. I again thank Dr. Hosi for spending time, and I thank the ICP and AP and ICP chapter for giving this opportunity. We'll see next week, maybe probably last sessions of course, and July onwards we have a testing mode there. So thank you once again. With that, we can close the sessions. Thank you all.
thank you, Suresh. Thank you, ICP and APA. Thank you. Have a good evening.